इसी साल तो ठीक है तो गए थी और हाँ ताकि उधर जो है ना सारी ईमानदारी और ये वो भी बड़े परेशान जी, अस्सलाम वालेकुम क्लास, हाउ आर यू? आपको मेरी आवाज़ आ रही है सबको? अच्छा, जूलियस है, इकरा है, साबिया। ओके, कल कर रहे थे ठीक है, कार्डियोवैस्कुलर सिस्टम हमने स्टार्ट किया हुआ है। ओके, बताओ कुछ मसला है? खाना बंद कर रही है। मेरी ना सेवन तरफ से हिंदुस्तान मेडिकल मुझे क्लास है। इसका क्या आप 00 क्या लिखना चाह रही हैं? class, are you here? Are you able to listen me? अच्छा, अभी स्टार्ट करते हैं कि फ्रेमवर्क फॉर द कार्डियोवैस्कुलर एग्जामिनेशन। आपका एक फ्रेमवर्क है ना? फ्रेमवर्क तो बेसिकली ये सारा एक असेसमेंट का एक फ्रेमवर्क होता है कि आप किसी सेशन में प्रोसीड करना है, क्या स्टेप आपसे पहले चलते हैं, कौन सा स्टेप सेकंड पे करना है, कौन सा स्टेप लास्ट में करना है। ठीक है, तो कार्डियोवैस्कुलर सिस्टम में सबसे पहले आप जनरल इंस्पेक्शन करते हो। जनरल इंस्पेक्शन में पेशेंट इल है, शॉकिंग सस्पेक्ट, उसकी हैंड देखिए, टेम्परेचर, स्वेट, नील, रेडियल पल्सेस देखिए, रेट उसका रिदम, ब्रेकियल पल्सेस, रेट, रिदम, ब्लड प्रेशर, फेस, ब्रेकिंग पफी करनी है, आईज। तो कल हमने आपकी फाइंडिंग्स, मैंने आपके स्लाइड में फाइंड किया, आई थीटा दिखते हो, कोई accumulation of the X या इस तरह से फ्लैग तो नहीं बना हुआ। टंग, कैरोटिड पल्स, जनरल pressure and pulse, waveform, inspection of the precordium inspection है, और position of the precordium, precordium, what is the precordium? The space in which heart lies, and auscultation of the precordium, auscultate करें आप, it's जो इसकी landmark है, heart के dynamic maneuvers, its lung abscess, abdomen, peripheral pulses, edema, assessment, peripheral veins। अच्छा, ये पूरा ना आपके पास फ्रेमवर्क है जिसमें आपने प्रोसीडिंग करनी होती है, किस तरह से आपकी कार्डियोवैस्कुलर सिस्टम को असेस करना है। ठीक है, general principle of assessment of the cardiovascular system, the precordial examination. Precordial examination basically focusing on the anterior chest wall. It's determine the status of underlying cardiovascular structure. Precordial examination technique are the inspection, palpation, auscultation. ठीक है, arterial pulses examination, skin is inspected during the cardiovascular examination. Neck vein, venous pulse examination determine the characteristics of the venous pulsations and central venous pressure. Integrates this when assessing the person. Next, general principle of assessment of cardiovascular system patient preparation. Yes, quiet room should be privacy, positioning, and sitting or lying on the exam table or bed. Adequate lighting, exposure of the body parts, the cardiac examination position, examiner stands on the right side, and precordial landmarks. Precordial landmarks देखें तो आप सेकंड राइट इंटरकॉस्टल स्पेस पे एयरटेक एरिया है, आपने ये सब में आप देखेंगे सिर्फ 4 स्टूडेंट हैं, और मंडे को मैंने एक टेस्ट अनाउंस किया हुआ है मस्क्यूलोस्केलेटल का। डिसमिनेट दिस इंफॉर्मेशन टू ऑल इकरा। इसमें मुझे अब ये नहीं कि किसी कोई मस्जिद में ऐलान करवाना पड़ेगा, ठीक है, सबको कह दो। और अब 4 स्टूडेंट हैं, जितना हमारा लेक्चर ये जो मिस हो रहा है उसकी रिस्पॉन्सिबिलिटी वो खुद वो है, ठीक है। आदमी कहते हैं हमें सब फेल हुए पड़े होते हैं। 11 स्टूडेंट हैं, हेल्थ असेसमेंट में से इतने फेल हैं, एसीएन में से भी इतने फेल हैं, तो आप आपकी रिप्यूट अच्छी नहीं है पर प्रिंसिपल की नज़रों में किसी की भी। पल्मोनिक एरिया, सेकंड कॉस्टल लेफ्ट इंटरकॉस्टल स्पेस, एंड ट्राइकेप्स एरिया इज द फिफ्थ इंटरकॉस्टल स्पेस। Left lower sternal border. Thickened mitral area is the fifth intercostal space left of the mid-clavicular line. These are the landmarks of the cardiovascular system, and you have to memorize it because these are the areas where you make auscultation and you have an idea that where the bell of the stethoscope basically lies in an exact anatomical position. Okay. Examination and documentation focuses basically the vital signs, um, BP, pulse rate, its rhythm, respiration, temperature, orthostatic changes, blood pressure and heart rate, and pulses paradoxes. What is a pulses paradoxes? What is a pulses paradoxes? Ifra, what is a pulses paradoxes? Abnormal large decrease in stroke volume. सिद्रा जमील, abnormal large decrease नहीं, पल्सेस पैराडॉक्सिस है कि आपकी रेस्पिरेशन के साथ जो है ना मेरे ख्याल हार्ट रेट जो है ना वो कम होता है, ठीक है ना, या बढ़ता है। आपने ये कंसेप्ट कहाँ से लिया भाई? ठीक है, abnormal large decrease। आपने जो है ना वर्डिंग यूज जो है ना वो थोड़ी की है, अगर आपने गूगल इसको किया है ना, abnormally large decrease in a stroke volume, how systolic blood pressure and pulse waveform during inspiration, कि जब आप इंस्पायरेशन करते हो तो तब ये कम होता है, पल्सेस पैराडॉक्सिस। ठीक है, प्रिकॉर्डियम में आप इंस्पेक्शन करते हो, पल्पेशन करते हो, आस्कल्टेशन करते हो। इंस्पेक्शन में पल्सेटाइल मोमेंट यानी थिन लोगों में होता है ना कि हार्ट जब बीट कर रहा होता है तो वो नज़र आ रही होती है। यस, एंड pulsatile movement, its vibration. Auscultation is the heart rate and the rhythm, heart sounds and murmur. Arterial pulses, veins, peripheral neck is the pulse contour, its amplitude, distension, height of the venous pulsation. Note palpate and auscultate the carotid arteries. Previously previously discussed तो नहीं, हमने इसको डिस्कस तो करना है। ओके, कुछ पल्स की जो है ना एबनॉर्मलिटीज हैं। बेसिकली कोई भी कार्डियोवैस्कुलर कोई प्रॉब्लम है तो उसको बड़े अच्छे तरीके से आप पल्स का जिसको रेट, रिदम, उसका एम्पलीट्यूड, उसका कैरेक्टर, उसकी रेगुलरिटी, उसकी इरेगुलरिटी, अगर कोई एक जो है ना बहुत ज़्यादा आपको एक्सपर्टीज़ है इसमें तो ये वो बहुत ईजी होता है कि उसको कार्डियोवैस्कुलर प्रॉब्लम को रूल आउट करना। ठीक है, अब ये कुछ कैरेक्टरिस्टिक्स हैं पल्स इसके पल्सेस के। ठीक है, इसको आप देखें कितनी है, बुक भी आपके सामने पड़ी होनी चाहिए। तो ये जब जो असेसमेंट है ये आई थिंक आज हम नहीं करेंगे, कल करेंगे। अभी आप जो है ना इसको पल्स की जो है ना वो टाइप्स को थोड़ा सा रिव्यू करें, लैंडमार्क्स को थोड़ा सा रिव्यू करें। ठीक है, और मैं आपको एक ना एक वीडियो भी दिखाता हूँ इसकी।
This video begins with a brief overview of health history taking, followed by the anatomy of the vascular structures of the neck, examination of jugular venous pressure and the carotid pulse, anatomy of the heart, inspection, palpation, and auscultation of the heart, a description of heart sounds, and attributes and grading of murmurs. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings.
How are you doing today?
Pretty Good, thanks.
The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you will record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to neck vessels and the heart include chest pain, palpitations, and shortness of breath, orthopnea, or paroxysmal nocturnal dyspnea. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. A productive cardiovascular examination also requires that you think about the possible meanings of your individual observations, fit them together in a logical pattern, and correlate your cardiac findings with the patient's blood pressure, arterial pulses, venous pulsations, jugular venous pressure, the remainder of your physical examination, and the patient's history. With the patient's health history in mind, you are now ready for the examination. Before beginning, let's review the three key cardiovascular structures in the neck: the carotid artery, the internal jugular vein, and the external jugular vein. The carotid artery is deep to the sternomastoid muscle. The internal jugular vein lies beneath the sternomastoid muscle, adjacent to the carotid artery. The internal jugular vein is not normally visible. The external jugular vein runs at an angle along the sternomastoid muscle toward the clavicle. The external jugular can be observed fairly easily. Jugular venous pressure, or JVP, is a measurement of the elevation at which the highest oscillation point, or meniscus, of the jugular venous pulsations is usually evident. The measurement reflects pressure in the right atrium, that is, central venous pressure. Estimating the patient's JVP is one of the most important and frequently used skills of physical examination, and often the first step in your cardiovascular assessment. In the beginning, estimating the JVP will seem difficult, but with time, you will find that the JVP provides valuable information about the patient's volume status and cardiac function. The JVP is best assessed from pulsations in the right internal jugular vein.
You can lie back for me.
Raise the head of the examining table to 30 degrees, and with the patient supine, place the patient's head on a pillow to relax the sternomastoid muscles. Then adjust the patient's gown and drape. Using tangential lighting if necessary, examine both sides of the neck. Then turn the patient's head slightly to the left, since the physical examination is conducted from the patient's right side. Focusing on the right side, identify the external jugular vein. Then find the internal jugular venous pulsations. If necessary, raise or lower the head of the bed until you can see the oscillation point of the internal jugular venous pulsations in the lower half of the neck. Look for the oscillation point along the sternomastoid muscle, between the clavicle and the angle of the jaw, or just posterior to the sternomastoid. Internal jugular pulsations have a soft, rapid, undulating quality, usually with 3 elevations per heartbeat, 2 of which are visible, and 2 troughs, whereas the carotid pulse provides a more vigorous thrust with a single outward component. Internal jugular pulsations are rarely palpable, whereas the carotid pulse is almost always palpable. Internal jugular pulsations are eliminated by light pressure on the vein just above the sternal end of the clavicle. The carotid pulse is not eliminated by the pressure. The level of internal jugular pulsations changes with position. In a euvolemic patient, the level in the neck drops as the patient becomes more upright, whereas the carotid pulse is unchanged by position. Finally, the level of internal jugular pulsations usually descends with inspiration, whereas the carotid pulse is not affected by inspiration. Measure the oscillation point of pulsation in the right internal jugular vein using the following technique. Extend an elongated rectangular object, such as a 3x5 card, from the meniscus point of pulsation, while extending a centimeter ruler vertically from the sternal angle, making a right angle. Establishing the true vertical and horizontal lines to measure the JVP may be difficult. As you place your ruler on the sternal angle, line it up with something in the room that you know to be vertical. Then place your card or other rectangular object at an exact right angle to the ruler. This constitutes your horizontal line. Now place the card at the point of oscillation of the jugular venous pulsations, making sure to keep the card horizontal. Then read the vertical distance where the card crosses the ruler. This measurement identifies the jugular venous pressure, or JVP, the vertical distance in centimeters above the sternal angle where your card crosses the ruler. Round your measurement off to the nearest centimeter. In this patient, the JVP is about 1 centimeter above the sternal angle, with the head of the bed elevated 30 degrees. Venous pressure is elevated above normal when it measures at greater than 3 to 4 centimeters above the sternal angle, or more than 7 to 8 centimeters in total distance above the right atrium, with the bed elevated to 30 degrees. The steps for measuring the JVP, when followed carefully, result in a measurement that is important for assessing the intravascular volume status in euvolemic, hypervolemic, or hypovolemic patients. Next, assess the carotid pulse. The carotid pulse provides valuable information about cardiac function and is especially useful for detecting aortic valve stenosis or aortic insufficiency. Your assessment will include both palpation to assess the amplitude and contour of the carotid upstroke, and auscultation for the presence or absence of overlying bruits. You should assess both the right and left carotid arteries, then compare. However, do not press on both carotid arteries at once. Assessment of the right carotid artery is demonstrated here. With the patient still lying supine, and with the head of the bed or examining table still elevated to about 30 degrees, inspect the neck for carotid pulsations. Place your index and middle fingers, or your thumb, on the right carotid artery in the lower third of the neck. You should press just inside the medial border of a well-relaxed sternomastoid muscle, roughly at the level of the cricoid cartilage. Slowly increase pressure until you feel a maximal pulsation. Then slowly decrease pressure until you best sense the arterial pressure wave and contour. Try to assess the amplitude of the pulse. This correlates reasonably well with the pulse pressure. The contour of the pulse wave, that is, the speed of the upstroke, the duration of its summit, and the speed of the downstroke. The normal upstroke is brisk, smooth, and rapid, and follows S1 almost immediately. The summit is smooth, rounded, and roughly mid-systolic. The downstroke is less abrupt than the upstroke. During palpation of the carotid artery, you may detect humming vibrations or thrills that feel like the throat of a purring cat. Routinely, but especially in the presence of a thrill, you should listen over both carotid arteries with the diaphragm of your stethoscope. Ask the patient to hold breathing for a moment.
Hold your breath.
So that breath sounds do not obscure the vascular sound. Listen for a bruit, which is a whooshing, murmur-like sound of vascular rather than cardiac origin. A bruit suggests arterial narrowing. If present, a bruit would sound like this. You should also listen for bruits over the carotid arteries if the patient is middle-aged or elderly, or if you suspect cerebrovascular disease. Note that heart sounds alone do not constitute a bruit. Most of the anterior surface of the heart is made up of the right ventricle. The left ventricle lies to the left of and behind the right ventricle. It forms the left border of the heart and produces the apical impulse. The apical impulse is a brief systolic beat, usually found in the left fifth interspace, about 7 to 9 centimeters from the midsternal line. The impulse measures about the size of a quarter, roughly 1 to 2.5 centimeters in diameter. The right atrium forms the right border of the heart. The left atrium is mostly posterior. Neither the right nor the left atrium can be examined directly. Above the heart lie the great vessels. The pulmonary artery arises from the right ventricle and quickly bifurcates into its left and right branches. The aorta arises from the left ventricle. Your examination of the heart will consist of inspection, palpation, and auscultation. Let's begin with inspection and palpation.
I'm going to look at your chest.
To examine the heart, stand at the patient's right side. Have the patient remain supine with the upper body raised to about 30 degrees. First, inspect the anterior chest, noting any heaves or lifts. None are observed here. Careful inspection may also reveal the location of the apical impulse. When visible, the apical impulse is normally seen in the left fifth interspace at or medial to the midclavicular line. Later in the examination, you will palpate to more clearly identify the apical impulse. Following inspection, proceed with general palpation of the chest wall. First, palpate for impulses using your finger pads. Hold them flat or obliquely on the body's surface as you palpate in the right and left second interspaces, along the left sternal border, and in the apical area. Ventricular impulses may heave or lift your fingers. Then check for thrills by pressing the ball of your hand firmly on the chest in these same locations. If subsequent auscultation reveals a loud murmur, go back and check for thrills over that area again. Next, identify the apical impulse. The apical impulse represents the brief early pulsation of the left ventricle as it moves anteriorly during contraction and touches the chest wall. Note that in most examinations, the apical impulse is the point of maximal impulse, or PMI. However, some pathologic conditions, an enlarged right ventricle, for example, may produce a pulsation that is more prominent than the apical impulse. Using the palmar surfaces of several fingers, then for finer assessments, your fingertips, followed by one finger alone, palpate to confirm the characteristics of the apical impulse. You will note its location, diameter, and amplitude. Identify the location of the apical impulse by the interspaces in which you feel it, and by its distance in centimeters from the midsternal line. If you experience difficulty in locating the apical impulse, Ask the patient to roll onto his left lateral side.
Can you tip over on your left side, please?
That is, into the left lateral decubitus position. Palpate again using the palmar surfaces of several fingers. If you still cannot find the apical impulse, ask the patient to exhale fully and hold his breath for a few seconds.
Exhale fully for me and hold your breath for a few seconds.
Measure the diameter of the impulse in centimeters. Feel for the amplitude of the apical impulse. It is usually small and feels like a gentle tap. With experience, you will learn to feel the apical impulse in a high percentage of patients. However, obesity, a very muscular chest wall, or an increased antero-posterior diameter of the chest may make the apical impulse undetectable. Next, feel for a right ventricular impulse at the lower left sternal border and in the epigastric or subxiphoid area. While keeping one finger in the third interspace, place additional fingertips in the fourth and fifth interspaces. If the patient's chest has an increased antero-posterior diameter, palpate for the right ventricular impulse high in the epigastric area where it may be easier to feel. Auscultation of heart sounds is an important skill that leads directly to several clinical diagnoses. Before auscultating the heart, let's review normal heart sounds. Closure of the heart valves creates a pair of audible heart sounds. The first sound, S1, arises from closure of the mitral valve. Tricuspid valve closure may also contribute to S1. The second sound, S2, arises from closure of the aortic valve. Pulmonic valve closure may also contribute to S2. Ventricular systole occurs between S1 and S2. Ventricular diastole occurs between S2 and the next S1. The fact that diastole usually lasts longer than systole is helpful in distinguishing the two sounds. The abnormal sounds of S3 and S4 can be heard in early and late diastole. When auscultating, it's important to know your stethoscope. The diaphragm is better for detecting higher-pitched sounds, such as S1 or S2, the murmurs of aortic and mitral regurgitation, and pericardial friction rubs. The bell is more sensitive to low-pitched sounds, such as S3 or S4, and the murmur of mitral stenosis. When auscultating the heart, remember to correlate your findings with the patient's jugular venous pressure and carotid pulse. You will listen for S1 and S2 in each of the 6 listening areas. In the aortic area, in the right second interspace close to the sternum. In the pulmonic area, in the left second interspace close to the sternum. In the left third interspace. In the tricuspid area, in the left fourth and left fifth interspaces, and in the mitral area at the apex. The auscultation sequence will start with the diaphragm of the stethoscope and progress from the base of the heart, moving from the right second interspace to the left second interspace and down the left sternal border to the apex. Then, with the bell of the stethoscope, we will listen along the lower left sternal border in the left fourth and fifth interspaces. Then we will listen at the apex. Adjust your stethoscope so that you will be listening through the diaphragm. Begin listening in the aortic area at the right second interspace close to the sternum. Starting in the right second interspace helps orient you to the cardiac cycle. Note the cardiac rate and rhythm. Normally the rate is 60 to 100 beats per minute, and the rhythm is regular. Identify S1 and S2, and listen for extra heart sounds and murmurs. Murmurs are covered in greater detail later in this video. In the aortic area, and also in the pulmonic area, S2 is usually louder than S1. Still listening in the aortic area, but focusing more in the pulmonic area. Try to identify the inspiratory splitting of S2 into its two components. Its first component, A2, is from left-sided aortic valve closure. Its second component, P2, comes from right-sided pulmonic valve closure.
Now breathe deeply.
This physiologic split of S2A and S2P normally occurs during inspiration. During expiration, however, these two components are fused into a single sound, S2. Let's listen again.
Now breathe normally.
S2 usually diminishes in intensity, while S1 becomes louder as you proceed down through the third interspace and into the tricuspid area. Listen at the apex. Here at the mitral area, S1 is usually louder than S2. Now, switch to the bell of the stethoscope. Listen next along the lower left sternal border in the left fourth and fifth interspaces. Then listen at the apex. To improve your ability to hear S3, S4, and the murmur of mitral stenosis, place the patient in the left lateral decubitus position. Have the patient roll part way onto his left side.
Now tip onto your left side.
This brings the left ventricle closer to the chest wall and makes low-pitched sounds more audible. Then recheck the position of the apical impulse and place the bell lightly over that location. If the patient had an audible S3, it would sound like this. Now, notice how the third heart sound disappears when the bell is placed more firmly on the chest wall. Listen again with light pressure. With firm pressure. And once again with light pressure. Murmurs are differentiated from heart sounds by their longer duration. If you detect a heart murmur, you must learn to assess its timing, shape, location of maximal intensity, and radiation. Grade its intensity, and assess its pitch and quality. Palpating the carotid pulse as you listen can help you with timing. First, Decide if you are hearing a systolic murmur, falling between S1 and S2, and coinciding with the carotid upstroke, or a diastolic murmur, falling between S2 and S1. Murmurs are classified according to where they fall in systole and diastole. Systolic murmurs can be early, mid, or late systolic, or even pansystolic. For example, a mid-systolic murmur, as heard in physiologic flow murmurs or aortic stenosis, begins after S1 and stops before S2. Brief gaps are audible between the murmur and the heart sounds. Listen carefully for the gap just before S2. If present, the gap usually confirms the murmur as mid-systolic, not pansystolic. A pansystolic murmur, as heard with mitral regurgitation, starts with S1 and stops at S2, without a gap between murmur and heart sounds. Let's turn our attention next to diastolic murmurs. An early diastolic murmur, as in aortic regurgitation, starts right after S2 without a discernible gap, then usually fades into silence before the next S1. A mid-diastolic murmur, as in mitral stenosis, starts a short time after S2. It may fade away, as heard here. Or it may merge into a late diastolic murmur. A late diastolic murmur, as heard with mitral stenosis, starts late in diastole and typically continues up to S1. The shape of a murmur is determined by its intensity over time. A crescendo murmur grows louder. A decrescendo murmur grows softer. A crescendo-decrescendo murmur, as heard with aortic stenosis, first rises in intensity, then falls. A plateau murmur has the same intensity throughout. The location of maximal intensity is determined by the site where the murmur originates. Find the location by exploring the area where you hear the murmur. Describe where you hear it best in terms of the interspace, and describe the murmur's position relative to the sternum, the apex, or the midsternal, midclavicular, or one of the axillary lines. Radiation, also referred to as transmission from the point of maximal intensity, reflects not only the site of origin, but also the intensity of the murmur and the direction of blood flow. Explore the area around a murmur and determine where else you can hear it. Intensity is usually graded on a 6-point scale and expressed as a ratio. The numerator describes the intensity of the murmur wherever it is loudest, and the denominator, by convention, is 6, indicating the scale you are using. Intensity is influenced by the thickness of the chest wall and the presence of intervening tissue. Using the 6-point scale, grade 1 indicates a murmur that is very faint and heard only after the listener has tuned in. It may not be heard in all positions. A grade 2 murmur is quiet, but heard immediately after placing the stethoscope on the chest. A grade 3 murmur is moderately loud. Grades 4, 5, and 6 are increasingly loud and accompanied by a palpable thrill.